I'm going to introduce our next speakers. We have Rachel Carmen Caesar and Lisa Yoshiko from Kaiser Permanente talking about demystifying data analysis in healthcare. So kind of picking up a little bit of where Shannon left off and talking about how to kind of make sense of all of the research that comes back from these great outputs. So with that, please welcome Rachel and Lisa.
Thank you, Emily. And I'd also like to thank the larger MadPow team in inviting us to speak today. To kick it off, we want to introduce ourselves. I am Lisa Radecki, and I work at Kaiser Permanente as an internal design strategist. And my journey at Kaiser Permanente really started in a regional level where I was working to help create new future care delivery tools. And I actually transitioned into a operation role. So now I'm at Kaiser Permanente Orange County, where I'm focused in the frontline care delivery and specifically around understanding patients and providers as they're going through the complex system of healthcare. I am one of the few human-centered design trained professionals in operations. So a lot of my work is really advocating for the different design processes, as well as training people who are interested. People come up to me a lot of times and they say, I know it's important to get the patient voice, but how can I squeeze it into my work? So we'll be talking about some of that during our presentation, and I'm going to pass it off to Rachel.
Hi, good morning, everyone. I'm Rachel Carmen Caesar. I created Culture of Health+Tech Consulting, which is a boutique research and design firm specializing in the health and tech industries out here in sunny Los Angeles, California. I see a lot of people calling in from in the chat here from some cold places. Oh, I see Cat Hill. Hello. I see some familiar names. I'm also a public health researcher here at the University of Southern California at the Keck School of Medicine. And a lot of my work looks at substance use, particularly looking at cannabis use during pregnancy. Let's go ahead to the next slide, please. So there's kind of three things we want to talk about today. It's a little, I'm on a small screen here, but it's a little hard to see, but really within the context of health, what Lisa and I want to focus on is to bring back the human into design work. And one way to do that is adding what this method and theory of analysis of grounded theory, adding grounded theory to your toolkit. For those of you in the audience, maybe this could be a top, a method to up your design principles if you're working in service design or UX design, or maybe you're on the health services and implementation side. But the first thing we want to kind of focus on is advocating for design based on people's experience. The second one is designing around you and your experiences and not other people's actually really introduces bias into the work we do. And the third, in terms of focusing on people's experiences, pivoting away from your own experiences and limiting bias, we're hoping to kind of use grounded theory as a method for doing that. And Lisa will walk us through in a little bit a case example of how to do that. Next slide, please. So for the first thing we want to really kind of bring home is the advocating for design based on people's experience. And there's so many of this that's not there, that we're designing just based on what we think is right or without consulting with others. And so this is Dodger Stadium here in LA, which is a big vaccine distribution site. The data shows people are getting vaccinated. There's a light at the end of the tunnel. But what we don't have in this big data or the gatherings of what's going on Dodger Stadium is who's not making it to the Dodger Stadiums or the Disneylands. Who are we missing here? And then the next slide, please. A lot of times when we have a problem, the problem here is let's get more people vaccinated. And the solution we just naturally go to is well, let's create a website or app for that. So this is a vaccine finder, and there's a lot of different iterations of this. And this might work for a lot of people. But we still don't really know who are we missing? Next slide, please. And so really, what would it look like to design vaccine sites or vaccine rollout plans are actually based on people's experience? It's almost like a revolutionary or crazy idea. And this is some of the work we're trying to do at USC and across California of, well, what about if we ask community health workers or promotores? What about if we ask LGBTQI service providers and we talk to them and they said, you know, as a trans person, I'm just afraid to leave my house to get beaten. How am I going to get to what looks like the apocalypse here at Dodger Stadium? You know, I need to have a car to be able to get to Dodger Stadium. I have to take off work. I arrive there and, you know, there's a whole bunch of protesters. So you can see just having some, as Shannon kind of pointed out in her talk, having these one-on-one or focus group type of conversations really helps us get closer very quickly to what we can be designing from other people's experiences. Next slide, please. So for the second kind of point we want to drive home is designing around you and your experiences. If you're not going out there and talking to people, this actually introduces bias, and this can have some real consequences. Next slide, please. And, you know, we know some of these, you know, this is a classic one, Google Photos, y'all fucked up. My friend's not a gorilla. When Google Images had this, Google Photos had this crazy algorithm that if you were Black, it would identify and organize your photos as gorillas. So there's some real consequences to big data and algorithms. And the next slide, please. We see this in healthcare as well. You know, this is from Stat Health. Vaccine registration technology is failing. Here's how the Biden administration could fix it. And the author goes into like, well, what's the solution of bad tech and not being able to get access to the vaccines is let's get some better tech. Let's just have Apple or Amazon do it. And then next slide, please. But we know that, you know, the solution to bad tech is not better tech. You know, the Amazons, Apples, and Googles of the world. And this is an example, this from New York Times. This is a racial divide. There's a racial divide in speech recognition systems. Researchers say technology from Amazon, Apple, Google, IBM, and Microsoft misidentified 35% of words from people who are Black. White people fared much better. So we're seeing, you know, we're not saying, and we'll go to the next slide, we're not saying tech is bad, you know, using quant or surveys or big data or algorithms, they're all bad. We're not saying that, but we do just want to be mindful of every time there's some kind of problem, we naturally, as designers or in healthcare or in research, let's go to a tech solution, or let's use mHealth, or let's, you know, and doctors are feeling this too. This is from the New Yorker, from Atul Gawande, who's, you know, tech doesn't need to always be the solution, and why doctors hate their computers. I mean, it's really changing how people work and relate to one another. And what might it look like to take a step back? And I mean, I think a lot of times we turn to tech and big data and algorithms is that we're worried about biases. We don't want human biases and all our quirkiness and messiness to slip in. But what we're really creating with these type of technologies and data is we're actually creating more biases and harm. And so we'll go to the third side. And that kind of brings us to our next point. Okay, so we want to get at people's experiences. We want to limit our own personal biases from that seeping into our work. So how do we do that? And, you know, thank goodness in qualitative research or human-centered design, which all design should include humans in it, the way to kind of limit those biases and get closer to actual experience, a lot of what we use is called grounded theory. And we'll go to the next slide. And grounded theory, and a lot of the work that Lisa and I do, and I'm sure a lot of you here in the audience, it's not glamorous. You can see from this photo. It's just sitting and talking to people, but mostly really listening. You know, there really is no substitute for actually sitting down and listening to other people and their experiences and interacting with them. And not just during the interview or focus group process, but also later, and Lisa will go through this more, during the analysis process. That interaction keeps continuing, that listening keeps continuing. And this is just kind of a little reminder from us, like, this is also data. I mean, we're used to seeing numbers and percentages and stats, and that's helpful too, but it can only really approximate these stories, these experiences, the loves and hates that people have with our healthcare system. And then the next slide here. So I'm just going to put here in the chat, how many of you maybe have heard of grounded theory or maybe used it before? It's getting its name out there. Maybe not everyone has heard about it. And then kind of my second, okay, Amy's heard of it. Shannon's heard it but hasn't used it before. Allison's heard of it. And then how many people of you maybe have heard of Brene Brown? She actually has a little, she's probably like our most famous person who's like referenced. Yes, people like love her. That's why I was like so excited when I found grounded theory in her book, or a colleague of mine told me on LinkedIn. I got super excited. Like, yes, there's someone who's saying it better. But Brene Brown says the mandate of grounded theory is to develop theories, or kind of like these confident statements we can make about the data, to develop theories based on people's lived experiences rather than proving or disproving existing theories. And a basic tenet of grounded theory is all is data. Like everything people are saying, everything they're experiencing is data. And that's something we want to kind of to follow and understand. And then next slide, please. And so, you know, the theory part, that kind of sounds scary, but really we won't go into like the 4 steps of actually how to go through it. That could take like a whole 6 hours. But really what you're looking for in listening to people and their stories and experiences is, well, what can I confidently say about the 20 people I talk to or the 100 people I talk to? And really it's, you know, thinking about grounding our work and design work in healthcare on people's experiences, moving away from our biases, and really looking toward a method and analysis that moves toward being accessible, replicable, and transparent, you know, not just across our teams, but different stakeholders. And this is a really great process if you're working with non-researchers or people who've, you know, never done research before. So with that, I'll pass it to Lisa, and she's going to walk us through what this process actually looked like in the context of her work at Kaiser Permanente.
Thank you, Rachel. Those were some great examples of how qualitative research is really important to design new services. So like Rachel said, I'm going to walk us through a project that I did at Kaiser Permanente, Orange County, where we used human-centered design methods to improve the patient care experience. And we specifically focused in the emergency department. Our team came together with one ask from executive leaders, and that was to reduce member complaints and grievances to enhance the member satisfaction, retention, and loyalty. So our team set out to identify key systemic opportunities for change and to build new solutions that better support Kaiser Permanente services. Typically what would happen is you'd sit in a conference room and people would start to share, oh, this is what I think is going on with the patient. A lot of assumptions are being thrown around, and maybe that's from some quantitative data or just the person's perception. You know, I've been in this role in this department for 20 years. I know the member. The issue with this is that a lot of times we only usually see the symptoms of a problem. So if we're designing to solve the symptoms, we're doing a Band-Aid approach where we're really just solving for the small issues. We're not looking at the larger issue at hand. And if we just took a little bit more time to understand people's emotions and their lived experiences, we'd have a better understanding of the actual problem to solve. Now, I'm not saying that quantitative research isn't a great starting point. I think that quant and qual really work best when they're working together, and that's exactly what we did with our work. We used the quant data to really focus in on our research goal. So the ask, improving the care experience for an entire healthcare system, is pretty daunting, especially since each department is very unique in the services that they provide patients. And our team knew that we needed to do a deep dive to really understand what's happening in a specific department to really make a significant impact on the data. So we jumped at the opportunity to use the existing member complaints data, and we actually built a Tableau dashboard. And through this dashboard, we created data visualizations that helped us identify the emergency department as a department that could really benefit from doing a deep dive and the research to understand what's going on and why are they getting these complaints. Another reason that we made the dashboard was because we wanted to make it really visible, the complaints to managers in one centralized location. So they could look at what's going on in their department, but they could also track it over time. And making it accessible and actionable has really been a positive culture change for Orange County service area. But of course, quantitative data doesn't really tell us the whole picture. We really needed to get into the department, go into that ED and see what's going on, what is the experience that people are having. And with that, we set out to do some research. Our small team put together a research plan where we talked to both patients and providers. And why we did this was because we knew that if we wanted to make a sustainable solution, we really need to see both sides, all the users that are involved in the service. If we design new offerings for, say, just the patient, when we go to implement, it might fail because the staff don't understand why they're doing it. So it must be desirable for all the users and all the people that are interacting with the service. With this, we talked to 16 ED stakeholders, and they had various backgrounds. We had some managers, clinical staff, we had ward clerks, financial consultants, and security. And why we did this was because we really wanted to get a holistic approach of what is going on in the ED. So if a patient were to go in for a visit and if they interacted with these different touch points, what does that look like? And what does that experience hold? Along with the interviews, we did observation, where we sat in the waiting room and we talked with the patients and the caretakers to really understand what's going on with them as they were waiting for care. One thing that we consistently heard from the staff was that they wanted to spend more time with patients, but they just felt like they didn't have the time. For instance, in this slide, you can see on the right, there's a gentleman sitting down in the interview. And what I do a lot of times in the beginning of the interview, I do some activities, and this one was called the picture pull. And I asked him to choose 2 pictures that best represent his interaction with patients. And these are the pictures that he chose. The first one was where he was talking about, I really want to support my patients. I want to take the time and do whatever I can to make them feel comfortable. But then he also chose the alarm clock and said that I'm always on a time crunch. I have to consider the flow of the ED, and with that, I don't have enough time to dedicate with the patients. So we have all these rich stories that we're hearing, and it's a lot of information, hours of recordings. What do we do with that data? Well, that's where we get into the analysis and the fun part, where we're really trying to make sense of the mess. So with grounded theory, I use it to structure the mess and make sense of it. And on the right, you could see a snapshot where I pulled the patient and caretaker comments from around 300 unique ED member complaints. I used their specific voice, their phrases to code the data. Now this can take some time because you have to walk through each data point and identify the key themes. But with this, it brought me closer to the content and really connecting with what's going on for these patients or their caregivers. What are their motivations, their emotions, and their experiences, perception of the ED visit. We let them define the problem and their concerns with their visit. And by this point, we can then start to see different patterns and opportunities emerge. And by that, we can build the insights and some design principles or requirements to start to develop new solutions to meet these needs. But along with all this information, how do we share it out with others who aren't closely tied to the data? How do I quickly align with my teammates who aren't in the interviews or the other people who are involved in the work? As Kim Irwin, one of my old professors who also works in healthcare research and innovation, she says in her book, Communicating the New, that there are a lot of different frameworks that we can use to communicate core concepts and model making is one of them. So as you can see in the slide, it's a little blurred because of confidentiality purposes, but this is a model that I created. And I use a lot of models in my work to really understand the data even further. I'm a very visual thinker, so as I build these models, it reveals more to me what's in the data. But it's also really great to take it to presentations and to talk to people using this tool as kind of a facilitator or an anchor in the conversation. We can reference it and we could reflect back to it and keep true to the data at hand. I think this process is really helpful to engage others as they push ideas forward. So we did just that with our presentations. We talked to, let's see, the ED managers and our core team as we did a working session to create new solutions, but then we also brought it to a larger group of around 200 managers in the ambulatory setting. And in that sense, we wanted to share the best practices for the member complaints, but also share the research approach that we took to understand what the member journey or patient journey was like. So at this point, the ED came up with some great solutions, and it was all based off of the data, the quantitative and qualitative data. So they were thinking about the whole service. It wasn't simply one initiative that resolved the issues. It was really a strategic approach in setting expectations for the member and finding ways to support the staff. And with all these great ideas, they had to prioritize. And how they did that was we wanted to focus on initiatives that were feasible, viable, and desirable for both staff and patients. We knew that we wanted to have a low fidelity implementation because we wanted to work it into an already busy workflow. But we also wanted to try to use any resources that were existing so that it was easy to also implement. So I'm going to talk through just a couple of the interventions that took place. One, which is highlighted on the right, is a care card that the staff would use. So they use this card as a communication tool. They sit down with the staff and sit down with the patient and they talk to them about what does your experience look like during the visit. It's an expectation setting. So on a part of it, it shows the different tests that the physician might have ordered, and it shows how much time it will take to get those results. But then it also shows who the care team is and who they could depend on throughout the visit. This was really great for the patients because it was level setting, but then also for the staff, it was worked into their workflow so they could take that time that they wanted to sit down with the staff and the patients and talk. Another thing that we did was we provided more empathy training for the staff members. We have a great care experience team that teaches these practices, and so we brought them in to talk about empathy and the patient perception, and we created a service recovery escalation plan. In this escalation plan, we give the staff different tools that they could use to help members, patients, if they're upset, and to resolve it at point of service. If they're not able to resolve it, then they could escalate it to their manager. Maybe it's a manager in the radiology department because the patient was upset with the care there. With all these initiatives in place, the ED actually saw an increase in their satisfaction scores for two different surveys. One, which is external, the NRC, and then one internal, KP, internal satisfaction survey. So that's great. And they also were able to track over time using the member complaints tableau, how their initiatives were reducing the complaints volume. So to wrap things up, I just want to share some lessons learned. One is reducing the risk of failure. So through taking the time up front, doing the research, we are identifying the true needs. And also, we don't really need to do a huge ethnographic research project to get at the qualitative data. You can use existing data, like our team, we use the member complaints data seriously, and we comb through those data points. And then secondly, talking to people validates the design decisions because it's all based off of their needs. And so when we go into implementation, it makes sense to them. For instance, for the KP staff, they had the buy-in when we implemented because they felt like their voice was heard because we talked to them and they understood the decisions that we made. And then finally, the ability to quickly iterate and pivot so that you don't have to start from scratch. You don't have to go back to the drawing board. Being an internal consultant is really great because I could see a project and some solutions mature over time as they go through different iterations, but I could also see them spread. And in this project, the ED initiatives actually spread to other emergency departments in Kaiser Permanente. But one of the even better things was that the design process of doing the research and the analysis, that spread to different departments. For instance, the radiology department, they took on some of those methods and they looked at their own patient experience and started to identify their own initiatives. And with that, they've seen some great positive change. So it's really exciting to see that Kaiser Permanente Operations is taking on the human-centered design approach to really put the patient in the center of any design decisions made. And I'm just excited to be able to work with the frontline staff to really come up with some great solutions. So I'm going to pass it back to Rachel to wrap things up. Thank you.
So just real quick in terms of wrap up, we just want to kind of iterate. We went kind of through 3 things. Oh, next slide, please. Oh, perfect. It's a little lag on my side. Just kind of 3 things we walked through that we wanted to have as takeaways to send back to you all. You know, just the first one in terms of focusing on people's experiences and not to just rely on big data or algorithms. From the chat, I'm gonna throw an affinity mapping in there because a lot of times it's really easy to go from data to the map and the map becomes something very different. And there's really no substitute to listening to others' experiences, not just during the data collection phase, but as Lisa showed during the analysis phase as well. The second point, and trying to, we never move away from this completely. It's always there, whether it's algorithms or tech or even the work we're doing. The best we can do is try to limit it and to really bring the human, not be afraid to go outside the lab, bring the human back into our work and keep interacting with patients, providers, and caretakers. And that's really the best way we can limit bias and not to have our design work and our research be based on our own experiences. And then the third one, as Lisa walked us through, you know, there's a process, there's a method for this. It's not an app, but it does really help to promote listening to others and working with and across diverse teams in different contexts. That's, you know, that's a method that's accessible, replicable, and transparent. So thank you all so much. If you want to know more about us, I'll just put I see there's some questions coming in. I'll put in here in the chat our contact info. If you're interested in this method, if you want to learn more, please, or you just have questions about healthcare and design, please feel free to reach out to us and we're happy to continue the conversation.